So no, whenever you're ready, I'll start presenting the case.
Sure. Yeah, feel free to show the summary, Manaswini, and we can get started.
Is my screen visible?
Yeah, yeah, yeah.
Yeah, yeah.
Go, go ahead, Mohammed.
Okay, so my case is a pretty short case to the typical VMR. But it is five alquats. The fifth alquat is the diagnosis and the outcome of this patient. So let's start with the first alquat, which is the chief concern of this patient. Um, the patient he is a 49-year-old male presented to the clinic, cardiology clinic, with chest pain for the past 2 days.
I love it. Um, very classic and prototypical. I think most people have some sort of approach to chest pain. They might start with the no misdiagnoses. They might think anatomically. Um, they might just want to kind of hear, be so practiced, I guess, with the chief concern that they might just want to start hearing the story and kind of have more of a type one kind of reasoning rather than a systematic one of kind of recognizing a common illness script just based on the history, which of course is really key for any symptom, but maybe especially chest pain, given its commonness, given its both extremely common and benign causes, as well as common and severe causes, and rare and sinister causes. Um, so I guess since I sort of asked for the context, that's maybe something interesting to reflect on, the fact that we are in a cardiology clinic. So of course everything is going to be potentially contextually kind of biased to prioritize cardiac causes. And we don't know yet whether this person has a known cardiac history or whether they ended up in cardiology clinic even without such a sort of prior diagnosis. But I think it will be both important to kind of apply efficiency and prioritize um, uh, based on the assumption that they're in the right place, but also consider the possibility that they're not at all in the right place. Uh, and just be aware sort of metacognitively of the bias we might all have when seeing a patient with chest pain in a cardiology clinic, right? Um, so maybe that's all the thoughts I'll share before we hear more of this story, Mohammed, if that's okay.
That's a great start and great thoughts. So my second alquat is the patient HPI and past medical history. So this patient describes multiple episodes of chest pain in the past 2 days. He describes them as a gradually increasing diffuse chest pain, does not radiate in other sites outside the chest, and it's related to physical exertion. These episodes were lasted for a few minutes and resolved spontaneously, especially if the patient rests. The last episode was on the day of this visit. Awakened the patient from sleep and was much severe than the previous episodes of pain. The patient also reports sweating and a breathing discomfort during these episodes. The review of system, there is no cough, no fevers, no nausea and vomiting. There's no abdominal pain. No other symptoms are reported. The patient past medical history, patient have two ischemic strokes. The first one was last year, and the second one was 15 days ago, for which he was hospitalized. He also has hypertension. Patient medication history, he take aspirin and clopidogrel, atorvastatin, and lisinopril. But these medications were prescribed to him last year after his stroke diagnosis, but he was uncompliant with these medications. His family history is unremarkable, and his social history, he had heavy smoking history, 50 pack here, 50 pack here, so 3 packs a day for the past 20 years. And he works in a gas station. And this is my second aliquot.
Thanks, Mohammed. What a beautifully told history with all the relevant details. And Steph, I don't know, were you able to catch that HPI from the beginning?
Yes.
Okay. Is anyone not thinking the same thing that this sounds anginal, right?
Yes, I think I caught your teaching points, Zavin, about not wanting to narrow or anchor, particularly in the clinical context of a patient being seen in cardiology. But Hans, you put it nicely in the chat. The pretest probability of coronary vascular disease here is incredibly high. We've enriched it with smoking history already of vascular ischemic disease. Maybe we'll learn more about sort of the mechanisms of the strokes, but presumably with vascular risk factors, kind of atherosclerotic ischemic strokes were the mechanism for him, as opposed to embolic. And then it's been tough for him to be on the medications to cause, right, secondary prevention of subsequent vascular events. So I think, yeah, the onus is on us to really evaluate for ischemia. History and exam just aren't the best tests in terms of likelihood ratio. This is a very, very classic story, but this is why our threshold to get troponins and ECGs on anyone with chest discomfort is so low. But in this patient, I think, again, the clinical story makes it very worrisome. Did you have other reflections, Abin?
Um, yeah, totally with you. I think that's the operating, I think diagnosis, I think, and the history is very classic, and you don't know what kind of severity of myocardial ischemia and kind of on the spectrum of unstable coronary disease we might be dealing with. So this person needs a 12 lead ECG right now, because there may be signs that are diagnostic of acute coronary occlusion, complete occlusion, and sort of indicate an emergent catheterization or thrombolysis, depending on access to a cath lab. So I think that's, you hear the story, you want an EKG as you're taking the history, right? You want it sort of to be in the works already. I will also just kind of make two other points here. So I love that exactly, and I don't want to mispronounce your name, Linji. Please correct me if that's not right. But there absolutely is a differential diagnosis here, even though there's such a high pretest. The risk factor is a classic story, but PEs can present very much with both anginal features from RV ischemia, a stuttering time course of pain, or even escalating pain if there's kind of continued embolization of a DVT. It doesn't have to be pleuritic. PEs can cause a lot of different features of pain. This really doesn't sound like an aortic dissection just based on where it is and how it feels. The quality, the exertionality, the non-radiating to the back. But dissections can present in sort of like a stepwise stuttering manner as well. And then finally, I'm curious what people think about the this background of having had a stroke a couple of weeks ago. Does that sort of course, they have vascular disease, right? They're at risk for coronary vascular disease as well. So in some ways, that enriches sort of this now being a myocardial infarction. But does that, I guess, are there other ways to connect just temporally with why there was an ischemic event of the brain and now there maybe is this like chest pain syndrome happening? I don't know. Anybody have any thoughts, or Steph?
I don't have any great links for, again, other than the underlying risk factors being so common, about anything for the diagnosis or treatment of an acute stroke causing it. I guess we haven't heard sort of what deficits were there. This is not, again, this exertional chest discomfort with sweating doesn't fit well, for certainly a musculoskeletal cause. But if we found out he had new, one-sided hemiparesis and there actually was like new chest wall pain, but I'm sort of, this is like 3 or 4 steps removed, that could any of his neuromuscular deficits sort of result in pain for that reason.
Mhm.
But again, the pain history remains pretty concerning for vascular occlusion.
Yeah. Yeah, my guess is just like if you take 100 cases like that, they're probably not directly connected. But the only things I can think of is if there's sort of a common embolic source into the cerebrovascular bed and potentially into a coronary artery, or I guess the timing isn't perfectly for this being like a stress-induced cardiomyopathy, kind of Takotsubo-like syndrome, but it could be, and we don't know what the sort of evolution of both physiologic stress from the initial cerebral insult, and then subsequently to the emotional kind of implications thereof in the subsequent days or weeks. Um, but there could be a relationship just through like a neurohormonal, I guess, mechanism, if we were to again think outside the actual kind of coronary ischemia. Um, so with that, maybe we can um, yeah, hear the next aliquot, and Steph, why don't you tackle that one?
Okay, great discussion. So, the third aliquot is physical examination, and I will share with you the ECG you asked for in the clinic. So, the patient generally is a middle-aged man with average body habitus, sitting in a wheelchair. His vital signs: his temperature 37.1 Celsius, heart rate is 90 beats per minute, his blood pressure is 146 over 94 millimeter mercury, and his respiratory rate is 18 cycle per minute. His oxygen saturation is a 98% on room air. The patient chest, cardiac, head and neck exam was unremarkable, as well as abdominal examination was unremarkable. So there's no chest wall tenderness, um, as you mentioned before. Also, there is no peripheral edema and there is no skin rash. The patient was on a wheelchair because of his severe weakness. He couldn't walk to the clinic. So, but he was pain-free during this visit. And the patient also, neuro examination was obviously abnormal. So we have his motor exam, um, left-sided increased tone, and also left-sided hyperreflexia, both upper and lower limbs. Also, his strength was decreased in in the left-sided upper and lower limbs, was 2 out of 5 in terms of the strength. So next, I will share this patient ECG. So let me share it with you. Um, I will replace the whiteboard. Is that all right?
Yes.
Can you see the ECG?
Yes. Thank you. We'll keep the ECG up and just share some reflections on the exam. Unremarkable, didn't point us really in one way or the other, which again, does not at all sort of lower the pretest probability for what we've been worried about with an acute coronary syndrome or stress cardiomyopathy. I think Mohammed, you did a nice job mentioning some pertinent negatives, though. Doesn't sound like with lack of edema that there's signs of volume overload or clinical heart failure developing right now. I appreciate the mention of the rash, because the clinical syndrome didn't sort of fit a zoster-related pain, but certainly that can cause chest pain, and you can have even pre-herpetic neuralgia before rash develops. So just appreciate you including those negatives on there. I think the exam keeps our differential diagnosis the same, really wanting to hone into ischemia. Let's see here, how to tackle the ECG. I think maybe solidifying specifically an approach to ischemia could be helpful. And I'll say here, this is normal sinus rhythm. The rate seems to be just under 100. And when you're reading an ECG for ischemia, you have a checklist of 3 changes that you're going to look for. Q waves, ST up or down, relative to the electrically quiet or silent time in the heart, which is actually the TP segment. Q waves, ST up or down, or T wave inversions. And the approach is to kind of run that checklist of 3 changes in the lead territories that correspond to different parts of the heart. So traditionally, people start with inferior lead 2-3 AVF, then they go to the septal leads V1, V2, anterior leads V3, V4, the lateral or apical, sometimes people say leads V5, V6, and then over to 1 in AVL, and then finally look at AVR, which is the lead that's sort of completely opposite the heart to some extent and can kind of give signs of sort of global subendocardial ischemia. So I see some thoughts coming in from the chat already. I think if we start with our inferior leads, do we see pathologic Q waves here? We don't. Do we see the ST up or down? And I would say in lead 2 as well as lead AVF, there's about maybe a millimeter or so of ST depression relative to the TP segment. There's a little bit of artifact in lead 3, so it's hard to say. So we do have some sub-millimeter inferior ST depressions, and the T waves are not inverted. You go to the very same checklist again for the septal leads, where I don't see any of those findings. I'm squinting to see if we think that there's kind of a little bit of elevation in V2, but I think it overall looks okay. Same checklist in V3, V4. No Q waves, no ST up or down, no T wave inversions. Maybe there's a hint of a slight ST depression in V4. And then V5 and V6, I saw a lot of you guys noted already in the ECG, in the chat, that there's certainly ST depressions in both V5, V6 and T wave inversions there, that if we look at 1 in AVL seem to be parallel there. So there seem to be submillimeter inferior ST depressions and lateral T wave inversions and ST depressions as well. Of course, we didn't read the rest of the ECG, so it's important to put this all into the context of, is there, for example, left ventricular hypertrophy, which it seems like there is, even just how tall AVL is meets one of the criteria for that. And of course, we want to compare this to a baseline, and Mohammed gave us such critical information, is that this is a chest pain-free ECG right now. Very important to have the clinical context of what is the patient feeling when you take this reading. There's always a lot more to say about ECG. Zaven, do you want to pick up other details or clarify or modify anything that we've missed with read for ischemia?
Yeah, I don't think you missed anything. I would just, I guess, emphasize like how helpful it would be to have a baseline ECG, and especially just with the fact that there is LVH suggested by the ECG, as Andrew said, like, a lot of these ST changes could just be like a chronic structural repolarization abnormality in the setting of that kind of thick ventricle. Specifically those, ST depressions, T wave inversions that y'all discussed. So if you see this EKG and it looked the same a month ago and a year ago, or there was like a gradual progression over months of years of these changes, then the abnormalities are explained. Whereas if the baseline ECG was available and had normal STs and T waves, which could still happen in a setting of LVH, then you would assume that this is potentially sort of a sign of ongoing or very recent, ischemia, and the T wave inversions are sort of reperfusion waves potentially. So I think it would really be helpful to have a baseline. Otherwise, you always want to assume the worst, right? You don't want to kind of have wishful thinking and say, oh, it's probably just, chronic structural, when there is a possibility that it's not.
So I guess seeing him in clinic, the exam is okay. we have an ECG. We're going to see if we've got a baseline or not, but I think our diagnostic plan is really going to remain the same. We're going to want troponins. We're going to want serial ECGs as well, particularly if he develops chest pain. A chest X-ray really sort of move forward. Doesn't seem like our needle has moved too much again towards or away any of the specific diagnoses by the ECG right now. But again, if under the assumption that they're new, yeah, these could be new ischemic changes consistent with the non-STEMI. Can turn it back to you, Mohammed.
Spot on discussion. So actually, I have a baseline description, baseline ECG. When he had the before 15 days, when he was hospitalized for the second stroke, his this ECG 15 days ago was positive for LVH by the electrical criteria, by voltage criteria, but there is no ST and T wave changes. So it was negative in the previous ECG. So I'm proceed with the fourth aliquot, some laboratory test. So in this patient, and now in the clinic, we sent, as you mentioned, troponins. So patient troponin was 25 nanogram per liter, so was above the normal range, about 99th percentile. And the patient white BC, hemoglobin and platelets were normal, as well as the liver function test, serum electrolytes, and renal function test also was within the normal limits. So at this patient, patient was refused to be admitted to the hospital at this point after getting his troponin, which was positive. And after 2 days, he presented again to the hospital, but now with acute onset chest pain and shortness of breath, as well as diaphoresis. And I have a representative second ECG at the emergency department.
Can we see it?
Okay, I will share my screen right now.
Ooh. Ouch. Ouch, ouch, ouch. There is still sinus rhythm. I do, I think everybody's seeing the ST elevations. And Mohammed, if you don't mind just pointing to them for everyone to make sure to be, looking in the same place in lead 2, lead 3, AVF, in V5, V6. Even there's subtle elevation in lead 1 as well. And then there are okay, so that's jumping out. All right, but I want to make the point that even in a situation like this, it's important to kind of be systematic in reading the EKG because there may be other significant rhythm abnormalities or other abnormalities that still need attention. So it looks like the patient's in sinus rhythm. There is a little P wave before every QRS. QRS after every P wave. I'm deliberately looking for any P waves that are not followed by QRSs because, yeah, if you could just actually scroll down to the lead 2 rhythm strip again. This is a situation where a patient could actually have an ischemic heart block as well. And there is a little bit of irregularity. Like if you look between the third and fourth QRS complex and the fourth and fifth QRS complex, right? It's irregular, but I don't see any kind of missed or skipped P waves that would make me concerned that in addition to kind of thinking about the coronaries and reperfusion, there may be kind of rhythm support interventions as part of the stabilization. So it looks like there's just a little bit of sinus arrhythmia, but no heart block. Okay. And then the other ischemic change in this case is the uh, ST depressions in V1 and V2 and a little bit in V3. Those three leads are kind of anterior pointing vectors coming out of the chest. So ST depressions in those leads, as well as the tall R waves in those leads, the initial positive deflection of the QRS, represent transmural ischemia of the posterior LV wall. And the tall R waves are evolving sort of necrosis, essentially Q waves that you would see if you were to place. So V1, V2, V3 coming out of the chest. If you were to put V5, V6, V7 coming out of the back, you would essentially see the mirror upside down of V1, V2, V3. I think one important just sort of prognostic, and this is an occlusion MI, needs emergent revascularization, but one important question is sort of at what level of the uh, arterial sort of branching is the clot present, and specifically whether it's proximal, sort of it's a posterior descending artery infarct, or whether it's a proximal RCA infarct that is going to also cause dysfunction, injury to the right ventricle, and potentially some of the AV node, SA node branching arteries that could result in rhythm abnormalities as well. And one way to have a best guess of that is actually to look at the relative amplitude of ST elevation in lead 3 as opposed to lead 2. So lead 3 points down and, sorry, to the right, and lead 2 points down and to the left. And if the ST elevation is greater in magnitude in lead 3, a rightward pointing lead, than lead 2, a leftward pointing lead, that actually has a decent positive predictive value of the RCA being occluded more proximally and the RV being involved, a finding that is absent in this case. And I actually forget the sensitivity of that finding, so I don't know if we could sort of confidently say that the RV is not involved. But my best guess is that this is a posterior descending artery occlusion, and the RV is not involved. But the posterior descending artery in this case seems to be of decent size. The apex of the heart, V5, V6, right, lead 1, also seems to be implicated here with an injury current. So there's definitely seems to be a lot of myocardium at risk, and certainly an emergency to try to treat as quickly as possible. Steph, anything you want to add?
No, I think that was great. Let's get him to the cath lab.
Yeah.
So that, guys, that was a great discussion. And also this patient had, during this emergency department admission, as we mentioned, he had shortness of breath, not only chest pain. On labs, he had positive skyrocket troponin and CKMB. So very correct pathway. This patient went to the cath lab. So I'm going to mention the last things of this case. The cath lab findings, there were an occlusion of the proximal circumflex artery. So this was the occlusion of the proximal circumflex artery, but unfortunately the patient died on the cath lab table because of ventricular fibrillation.
Mm.
Very tough outcome.
Yeah, that's really tragic, Mohammed. I'm sorry that happened, and especially with with the earlier presentation and the opportunity that the patient and the team may have had to prevent this. It's obviously not only a tragic outcome for the patient and the family, but it must be especially tough for the family to have to think about the decision that the patient made and had the right to make, of course, but that uh, I wish things had gone differently, of course. Um, how did you and um, other people taking care of him kind of process this?
Um, Actually, preventable uh, comorbidities. Um, is my voice stable?
Now it is, yeah.
Yeah. So patient have multiple comorbidities. The first one, patient have long-standing smoking history and uh, he smoked 3 packs a day for past 1 year, so that's a lot. Um, Patient have previous stroke, atherosclerotic disease, uh, patient non-compliance with medication. So all these factors uh, came together into um, outcome. So it was very hard for us, especially in the clinic when things are stable. Many things we can take care of are stable. There is no acute, it's rare to have an acute case, but I want to share that it was a tragic outcome for this patient, and it was much preventable. And this patient, ECG finding in the clinic was very concerning, but in the context of hypertension, sometimes may interpret it as a strain pattern of LVH. So having a basic, as you mentioned, Zaven, a baseline ECG, it is an important to compare between uh, if this is a new dynamic ST changes, or it is a long-standing, not very critical or important change. It was actually ultra short case to share with you uh, about this patient uh, with with occlusion, with coronary occlusion, and I'm excited to hear your thoughts.
Thank you, Mohammed. It's a sad outcome, but great to have a case that is something we see all the time and think about how to get better identifying it and talking to patients about it when we're worried about it. I think, yeah, my big reflection is really along the theme you mentioned of, the initial pain-free ECG, given the risk factors, given the clinical syndrome. And again, we later found out the changes were new, but yeah, not saying this is all repolarization abnormality. It's just all about the story and how high their pretest probability is. And rightfully so, you in clinic were very, very worried about this and recommended admission. So I think that, the ECG being abnormal, whether it fits with baseline or not overriding our sense based on the story and who the patient is of how worried to be. And again, this is why the threshold for checking troponins is very, very low, because it's sometimes hard to be able to sort of rely on the information you have and definitively rule it out or not. You have other thoughts or teaching points, Evan?
No, I think I'm also just grateful to have had a chance to learn and reflect from the case, and so thank you for that. I think I just saw Andrew's very accurate call that this was a left circumflex lesion, just to kind of reflect on the interpretation of the second EKG. And so, most people are right coronary system dominant, with the posterior descending coming off the RCA. About 15% are left dominant. And Andrew, I don't know if you want to share kind of like why you took that guess. In retrospect, for me, that elevation in lead one was probably the clue that there was kind of a high lateral LV wall involved too, and thus making it more likely that this was a left dominant circulation. But are you able to share that? Okay, okay. Thanks, Andrew. Yeah. Um, yeah, thanks again, Mohammed, for sharing the case. And um, Hans, please, if you want to just summarize some of the teaching points, and thank you, Manaswini, for scribing as well.
Yes, thank you very much for the case. It is something we actually see every day in the ER and even in walk-in clinics. Our patient presented with chest pain for 2 days, and here we use our 4+2+2 mnemonic just to rule out serious possibilities such as acute coronary symptom, an MI, a pericarditis, or just Takotsubo, or an aortic dissection. And the 2 and 2 are the lungs, which is a pneumothorax or PE, or an esophageal perforation obstruction. And here I have seen several cases with GERD being the big mimicker of chest pain. Our patient had a past medical history, which gave us a strong pretest probability for a coronary ACS incident. And when we looked at his present ECG, which was pain-free, we did not see any Q waves, and there was no ST elevation. However, the patient presented with elevated troponins, which then led to further investigations into an MI. When can we suspect from the ECG an MI? And Steph has given us a nice summary. We want to look out on several consecutive leads for ST elevations or ST inversions showing ischemia. Our patient had, for comparison, an older ECG, which showed a occlusion of a posterior artery, and in more detail, when he was undergoing an angiogram, he showed or came down with a proximal circumflex artery occlusion. And this artery supplies the lateral and posterior lateral wall of the left ventricle. Unfortunately, the patient died during the procedure from a ventricular fibrillation. So altogether, we had a very sad bread and butter case. Thank you very much for presenting this.
Thank you, Hans. Good to be with everyone, and hope you have a great rest of your day and week.
Thanks, everyone. Have a great day. Bye.